But I'll tell you what, it's 7 o'clock. I see that we've got Dr. Patel on. Hi, Dr. Patel.
Hi, how are you all tonight?
Good.
Thank you.
Yeah, we are just so delighted. This is a topic that we get lots of requests, and it's been hard to find a good speaker on this topic. And we are so fortunate to have Dr. and I apologize if I am saying your name wrong, Dr. Anu Patel.
Yeah.
She is with the Retina Institute of Michigan. Dr. Patel specializes in retina care and other medical and surgical care for all diseases and conditions affecting the retina, including the diabetic eye care, macular degeneration, retinal detachment, retinopathy, vitreoretinal surgery, and other conditions. So tonight she's going to talk to us about managing vision problems that are associated with Parkinson's and some of those other issues that we all have as we're aging. And we are delighted to have her. A quick announcement before we get started. As some of you may have heard, I am retiring. My last day will be May 6th. It's been the greatest honor and privilege of my life to work at Michigan Parkinson Foundation. I met the most amazing people. I have loved this job, but I'm getting old and I'm tired. and I think the foundation needs somebody younger with more energy than I have these days. So this will be my last meeting with
This
you.
is about the vision and Parkinson's.
And so I just wanted to let you all know that. I'm going to mute everyone now, and then Dr. Patel, you'll need to unmute yourself, and then you can share your screen. I'm muting everyone right now.
Are you muted?
Okay, now, but Dr. Patel, you can unmute yourself, and I'm going to make you the spotlight. There you go. Okay, you got to unmute. There you go. You're good.
It's not allowing me to share my screen anymore.
All right. How's this?
Okay, there we go.
Are we there? Okay.
Okay. Can you see my screen in the background here?
Yes.
Okay. Well, thank you all for coming and listening to this talk today. My name is Anu Patel, and today I'd like to talk to you about the eye conditions related to Parkinson's disease, the most common causes of visual disturbances in our patients and loved ones. Okay. So just a little bit about me. I was born and raised here in Metro Detroit. I trained here in Michigan and in New York. I returned to Michigan in 2013, and I served as a faculty at the Kresge Eye Institute in Detroit. I trained fellows and residents and medical students in medical and surgical diseases of the retina, as well as all of ophthalmology. And I traveled to many offices all around the state. So I've worked with a variety of patients in many, many different communities, and it was truly a pleasure to do that. In 2019, I changed directions and I opened up the Retina Institute of Michigan, which is actually down the street from the Parkinson's Foundation office in Bingham Farms. And I did that to have my own autonomy over my own practice and medical care and the way I was able to treat patients and who I was able to see and when I was able to see them. And just a disclaimer, I have no financial interest in any of the products or anything discussed here today. So today I'd like to start by talking just a little bit about the eye, the basics of the eye, and how it connects to the brain. I'd like to go through the main vision difficulties that we've identified in Parkinson patients, and then also go through some of the more common causes of vision loss as we age, because that applies to all of us. Just an introduction to the care team involved in vision disorders. So the center of this is ophthalmology or an ophthalmologist. An ophthalmologist is a medical doctor, a physician who did at least 4 years of ophthalmology specific training. So they are typically surgeons, but also physicians of the eye. On the other side of that is a neurologist. You're all familiar with neurologist physicians who did subspecialty training in neurology specifically. And there is this overlapping group called neuro-ophthalmologists. Neuro-ophthalmologists are either neurologists or ophthalmologists who did further training in the other field and really truly are the experts of the eye's connection to the brain. From ophthalmology, there are a few other branches that come together to make up the full eye care spectrum. So one thing that's commonly confused with ophthalmologists is an optometrist, or the field of optometry. Optometry is an adjunct field in this world where providers go through an undergraduate degree and then a few years of specialized eye training, where they learn a lot about glasses, refraction, and general medical care. And in many communities, they serve as the primary location for eye care before you require a specialist or a surgeon. There are eye care doctors called low vision specialists. These are special optometrists who focus on patients who've lost vision from macular degeneration or diabetes or other things. And they open up a whole world to various eye care services, including physical and occupational therapists, services for the blind. They're an excellent resource in all areas of eye care. And then also, after any physician trains to become an ophthalmologist, you can become a subspecialist within that field. And these are doctors that are glaucoma doctors, retina doctors, which is what I am, or adult strabismus pediatric ophthalmologists. So there's various subspecialty training. So it's not uncommon that somebody has 3 eye doctors because everybody does something different and takes care of a different part of the eye. So just looking here, so this is an embryological diagram of the eye, and this is the full eye model here. This is what the eye looks like when you're born. And what I wanted to point out is that the cells that become the eye start separating at 22 days after an egg and sperm meet. So that happens very, very early in the process. And most of the critical development of eye structures happens in the first trimester of pregnancy. To me, that's fascinating because there's so much that we depend on in our eyes, and that all happens so early in our gestation. And the eye continues to grow, but it reaches its maximum size by age 2. After that, your eye is the same size it'll be for the rest of its life. And just looking at the front part of the eye, so we all know what we're talking about here. So this is the patient's right eye, and you can see the upper eyelid and lower eyelid and the eyelashes. The white part here we call the sclera, which is the eye wall itself. Now the sclera is covered by a clear tissue called the conjunctiva. That's a mobile tissue. That's the tissue that can get pink in pink eye or red when you have a bleed on the surface of your eye. And then we have the iris, which is the colored part of the eye here. And the pupil. The pupil is the dark area right in the center of the iris that allows light to enter the eye. And if we took a cross section, so we split the eye down in half and turned it on its side, we would have this diagram here. So this is the outside, and this is the inside of the eye, and this connects back to the brain here. So light comes in this way and straight through the cornea, which is the clear covering of the eye, and through the pupil, the dark opening, and goes back through the lens and eventually hits the retina. And the retina is the visual tissue of the eye. It contains all of the cells that receive all of the light input from the world. It records that signal, and it collects all of the cells collect into the optic nerve, which transmits to the brain, and the brain then processes all of these signals to create the images that we see. So just a little bit more about the retina that receives this input. So this photo here on the top left is what we call a wide field photo. So it shows us the entire retina. And when you look here on the right, this is a magnified view of just the center here. So what you can see, all of this orange is the retinal tissue. These are all nerve cells, and it connects and combines to form the optic nerve over here, which is this yellow structure that will transmit to the brain. It's 1.2 million cells that travel back to the brain. The macula is this whole central area. So it's the center tissue of the retina that's most responsible for our vision, with the highest concentration of photoreceptors or vision cells. And of that, the densest area of sight, the most critical area for your central vision, is this area right here, which is called the fovea. And it's such a small area. If you look at the entire retina, it's this tiny, tiny dark area, even though you have so much retina. The part that's responsible for all of your reading vision and good functional driving vision, all of that is right here in the center, where there's no blood cells, just vision cells. And then I wanted to give a brief introduction to the eye muscles. So there are 6 eye muscles that control the direction of eye movement. And this is, again, this is a right eye diagram. So the easiest 2 muscles to understand are the lateral and medial rectus, so the horizontal muscles, and they move right and left. So the muscles, the corresponding muscles in your right and left eyes will fire to move your eyes all the way to the right. The opposite muscles fire to move your eyes to the left. But when we talk about up and down and other directions, so up and left or up and right, down and right, those directions are controlled by other muscles that have multiple functions. So the superior rectus, which sits on the top of the eye, it pulls the eye up when you want to look up, but it also turns the eye in a little bit. It rotates the eye and pulls it horizontally. And there are 4 muscles that have these kinds of functions, where they either depress the eye or rotate the eye, in addition to moving it up and down, or like right and left. And all of these muscles need to be firing. And one thing we'll talk about a lot is the lack of motor control in Parkinson's that can cause deficits in the firing of muscles to make the eyes move together. So now we'll go ahead and tackle just the most common vision difficulties associated with Parkinson's disease. So Parkinson's, as we know, is a degeneration of dopamine neurons in the substantia nigra, and eventually we get decreased motor output over time. And dopamine in the eye itself plays a role in many, many things. So it plays a role in adaptation to light, oculomotor control, contrast sensitivity, color vision, visual spatial construction, so making the image of the world that we see, and also spatial working memory, where something was the last time you saw it. So some of the most common complaints in Parkinson's patients are related to ocular surface disease. So this is disease and problems with the front surface of the eye, so not even looking inside the eye. Symptoms of ocular surface disease are very, very common and sort of general. They include irritation, blurred vision, grittiness, the feeling of sand or rocks in the eyes, crusting, redness, or excessive tearing. The first part of this that we're going to talk about is dry eye. So dry eyes in Parkinson's patients are caused by a decreased blink rate. Normal patients without Parkinson's blink about 20 to 30 times per minute, whereas Parkinson's patients can have a decreased blink rate that allows them only to blink 1 to 2 times per minute. So that's a significant decline in the blink rate. And the front surface of our eyes is coated by a tear film made up of 3 healthy layers of the tears themselves. When you blink, you replenish this tear film every time you blink. If you're not blinking nearly as much, you don't replenish the tear film, and the tear film just evaporates. What can happen is you can actually get a paradoxical tearing. So patients with dry eye can complain that they feel like they're crying all the time because tears are constantly running down their cheeks. This is what we call paradoxical tearing. This is reflex tearing. You're not producing real tears. You're producing just water because of the irritation, and that's what's running down your cheek. So just because you have tears running down your cheek doesn't mean you don't have dry eye. And dry eye is important because it can decrease your vision dramatically. You can go from seeing the 20/20 line on a vision chart to barely being able to see the big E because of dry eye. The treatment for dry eye starts with artificial tears. Artificial tears are lubricant eye drops. They don't have things like they don't have chemicals that will get the red out. So it's not Visine or anything that says get the red out. It's just a lubricant product. Some have preservatives and some don't. And what they're doing is they're treating the underlying dry eye part, trying to replenish those 3 layers of the tear film. And with that, they will hopefully get the redness out because the redness is caused by the irritation. There's also ointment that can be used overnight. The ointment is a thick salve that you put on the surface of the eye before bed. It helps to lubricate the eye all night long while you're sleeping. There are punctal plugs, which are tiny little silicone plugs that can be put in the tear drainage channels right here on the inner corners of the eyes. That can help prevent the tears from draining out. And finally, there are drops that can increase the tear production. And then the other part of ocular surface disease is called blepharitis. So blepharitis is actual inflammation of the eyelids and the glands around the eyelids. And it's definitely worsened in PD patients due to the autonomic dysfunction. And it can affect up to 18% of the Parkinson's population compared to just 3% of the general population. And so these 2 photos show that the top case is a little bit more just dry eye with mild blepharitis. You can see sort of the reddish pinkness of the conjunctiva here. And you can see how the eyelids are a little pink and thick. And there's a little bit of residual crusting on the eyelashes. And in this bottom photo, you can see it even more significantly. So even more thickening and inflammation of the eyelids themselves, and all of this crusting and mucus along the lash line here. The treatment for blepharitis, we do all of the other things to treat the dry eyes, the tears, the ointment, but also steroid drops and ointment can help to decrease the actual inflammation involved in blepharitis. And then there are special lid scrubs and products and lid hygiene to get the crust off, because the crust then causes more irritation and inflammation. Now I want to transition to some ocular movement disorders. So these are when the eyes are not moving together the way they should, when both eyes aren't moving. So there are 3 types of eye movement abnormalities, and we're going to go through each of them. I'll just name them briefly. There are deficits of smooth pursuit, deficits with Cicadas, and deficits with convergence. And we'll go through each of those to understand what the problem is and why patients can have difficulties. Double vision, which is also called diplopia, can be caused by a variety of things. But the first and most important thing is to understand, where could the diplopia or the double vision be coming from? So whenever a patient complains of double vision, the first most important thing to understand is it coming from one eye or both eyes? The way we determine this is if you think you're having double vision and you cover one eye or cover the other eye, if you still have double vision, even when you cover one eye, we call that monocular diplopia. That is most commonly caused by a glasses issue or a cataract issue, where the light is coming into the eye and spreading out abnormally, and therefore giving this sensation of double vision. So when you look at this hand down here, a lot of people describe this kind of vision, which may or may not be doubling, but might be blurring of vision. And that's when we try to tell, is it coming from one eye or both eyes? Binocular diplopia is true double vision. So that's when you're seeing double, and if you cover one eye, you no longer see double. And that's an issue with the eyes moving together. It is more common if you had a history as a child of having eye movement problems, and it can occur in up to 50% of Parkinson's patients, compared with just 20% of the general population. So this is a huge area of concern. And the biggest issue, one of the biggest issues, is that it can impair depth perception. So when it impairs depth perception, it can interfere with your ability to eat, navigate your environment, a whole host of things that require that. So we're going to talk first about smooth pursuits and saccades, which are movements that occur when the eyes move together. So smooth pursuit is this guy over here on the left. So smooth pursuit is when you are following an object or moving your eyes across space smoothly. So if you're scanning the room from the left side to the right side with just your eyes, that's a smooth pursuit. The other time when you see a smooth pursuit is every time you're reading in a book. So as your eyes go, read the line left to right, go to the next line, read the line left to right. That is a smooth pursuit because you're wanting to follow the letters smoothly across the plane. A saccade is when you quickly transfer your gaze from one area to the other. So you look quickly from this direction to something over there. So you need to be able to identify what you're looking at here, move your eyes quickly and identify what you're looking at over here. 75% of Parkinson's patients experience abnormalities in one of these two systems due to the inability to move the muscles or to generate the impulse to move the muscles. And this results in jerky movements. So when we talk about smooth pursuit, it impairs the ability to read because you are unable to smoothly move your muscles because there's jerkiness of the muscles that results in an impairment of your reading because you can't follow the words smoothly across a page. And when we talk about saccades, when you're looking, briefly from left to right, we can frequently our muscles, or even our eye muscles, have memory that allow us to identify, I should look exactly right here, and then I can look exactly right over here to find that next target. When you don't have the ability to move your muscles in that way, your eye muscles in that way, it requires you to depend on your vision, your true vision, to remember and to see exactly where your eyes need to move, which will help us transition to the next topic of the vision difficulties that patients can experience just with age. The third part of eye movement disorders are vergence eye movement disorders, and we don't commonly think of this, but there are times when the eyes, they don't move together left and right, they move in opposite directions to come together and to move apart. So the most common cause of this is when you're looking far away and then you look to read, our eyes move together to look at the target as it approaches. And as you look back in the distance, your eyes move apart to focus in the distance again. Abnormal convergence, or called convergence insufficiency, is when your eyes don't move. These opposite directions don't happen at the same time, which causes double vision and eye strain when reading. And it can also be a source of disturbance when driving, because when you're driving, you need to be able to look far away in the distance and keep your head up. And then you need to be able to converge on the dashboard, on the speedometer. So you need to be able to converge quickly. And then you need to be able to diverge your eyes again to look in the distance and continue driving. That rapid fire convergence divergence, if you can't do that, that can definitely be a source of difficulty when driving. And many, many times our patients can't even describe what the problem is with driving, just that they don't feel comfortable or they don't feel like they're seeing as well as they should be. There are treatment options for ocular movement disorders. And I found this picture, I thought it was interesting because I didn't know that she wore a prism in one eye. But the first part of this is to have an evaluation by an ophthalmologist with a good comprehensive exam. We're going to talk about other eye conditions later that can be contributing to vision difficulties, but it is important to rule out all of the things that can be causing vision problems. And a comprehensive ophthalmologist or a good comprehensive optometrist can help to start that workup. And from there, we can get a referral to all of the other specialists, adult strabismus, low vision specialists, optometrists, and others with training in fitting prisms. Prisms, like the one Hillary Clinton is wearing over here, are these are Fresnel prisms. So these are actually stickers. They're stick-on prisms that you put on the glasses that patients can get for reading, for distance. If you really need the prisms, they can be ground into your glasses, like especially made into your glasses. There are occupational therapists that can come out to your home and help to make things safer, to navigate because of ocular movement disturbances. So there's a lot of things. There are neuro-ophthalmologists that can work with patients, a lot of treatment options to make sure that you're seeing as well as you need to be seeing. There are also difficulties with color discrimination and contrast sensitivity. So color discrimination is when your ability to distinguish the differences in the primary colors. So red, green, and blue are the three primary color pigments, and your ability to distinguish it, you can see here, like distinguishing this 8 that's in red over this green background versus maybe a more complex distinguishing this 5, which is a variation of a blue-red over the blue background. So color discrimination. And contrast sensitivity. Contrast sensitivity is the ability to differentiate colors on a similar background. So for example, reading these black letters on a white background is easier than reading the dark gray letters that are on sort of the brownish gray newspaper print. And that's why reading on your computer or your iPad can be easier than reading the actual newspaper, regardless of the size of the font. Up to half of Parkinson's patients have problems with one of these two things. And we don't really know why this happens. It's definitely a dopamine problem, probably because there's not enough dopamine in the retina, and dopamine in the retina helps to control these functions. One thing that's important to note is that it has been shown that the amount of reduction in contrast sensitivity, so how much you've lost in sensitivity, correlates with how severe the disease is. So as the disease progresses, or as the contrast sensitivity decreases, the disease state, Parkinson's overall, is typically progressing. There are treatments that can be employed here, Levodopa Therapy that can be discussed with your neurologist, and again, low vision therapy and occupational therapy, because there are different absorption glasses and reading aids that can help to improve reading function. And the last section of this talk I'd like to go through is just looking at aging diseases of the eye, because these are things that everybody experiences, and it's hard to know what is caused by the Parkinson's and what is just a normal thing that can happen. So the leading causes of visual disability as patients age are cataracts, glaucoma, macular degeneration, and diabetic retinopathy. So there are some normal aging difficulties, and this is independent of any real disease state that happen to everyone. So first, cataracts. We're going to talk about them a little bit further, but cataracts happen to everyone no matter what. And over time, patients do need to change their glasses and eventually have surgery. Floaters. Floaters is one of the most common reasons I see patients in my office, and it's a bunch of black spots, specks. I think this is a really good picture because you can see all these sort of subtle black things floating around against a bright sky. It's a very common complaint. They can cause intermittent disturbances in vision. Again, it's a very normal aging thing to happen, to see them over time. And then contrast sensitivity, we're going to keep hitting this because contrast sensitivity, without any disease at all, contrast sensitivity will go down as your retina gets older. Sometimes it can be hard to tell, is it from a disease process or is it just normal aging? So cataracts are the lens of the eye. So when we're born, this is the lens of the eye, the circular structure here towards the front. When we're born, the lens is clear generally, and the fibers and its capsule, everything moves freely. The fibers that hold the lens allow us to, when we're young, look really far away and then hold a paper right up to our nose and still be able to see it. That's because everything is moving freely when we're very young. And as we age over time, we lose that ability to look far away and then look up close. And that's why over time, everybody will need reading glasses. And at some point, everyone needs new glasses because the lens itself starts to get cloudy. It starts to harden and opacify, which can make you need new glasses, even if you've never worn glasses before. But over time, you can get blurred vision with cataracts. So looking at this top right photo, this is a clear photo, and the top and further to the right, you see blurred vision. Patients commonly report difficulty with glare. So when you're looking at a circular light on the ceiling, it's not a circle, it has a star around it. Difficulty driving at night or in the rain, or halos around lights. And this photo here shows in a patient that doesn't have any glare, the light comes into the eye and is focused on the retina at one point. And so you don't see glare when you're driving. But when the light comes in and then is spread apart because of the opacities in the lens, you can get a lot of glare in your vision. A lot of people describe this. The treatment for cataracts ultimately is cataract surgery. And at some point, everyone will need cataract surgery. So again, another worthwhile point of seeing an ophthalmologist is to determine, are the cataracts what are causing your blurred vision or your vision difficulties? I'm going to talk briefly about glaucoma because it's very poorly understood. So glaucoma is actually a drainage problem in the eye. So the eye produces a fluid called the aqueous humor. And the eye needs to produce as much fluid as it can drain. There has to be an equal ratio of production and drainage so that the pressure inside the eye is a healthy, normal pressure. And there is a range of pressures that can be normal for anybody. But what happens with glaucoma is that there's either too much production or too little drainage. And when there's too much production or too little drainage, the eye fluid and the pressure inside the eye builds up. And it increases and it puts pressure on the optic nerve back here, which is where all of the vision cells have collected. The optic nerve is very sensitive to increased pressure over time. And if it's left alone for a long time, this is what results in glaucoma. So glaucoma is damage to the optic nerve because of high pressure. And so the damage in glaucoma and the danger of glaucoma is that it has no pain associated with it. And it happens very slowly, where patients start to lose the peripheral vision first. And because it's the peripheral vision, you don't even know that there's a problem until very late in the disease. So here we can see a patient with normal vision can see the entire screen. And in early glaucoma, you see a darkening of the edges. Later in glaucoma, that the area of vision gets smaller and smaller, and more advanced glaucoma, you really just have the center vision left. And I wouldn't even call this extreme glaucoma. Extreme glaucoma is when the whole thing goes black. You've lost all of the cells of the optic nerve because of pressure problems. The treatment for glaucoma is to catch it as early as possible. So whenever we suspect that somebody has glaucoma, we monitor them closely with visual field testing, pressure checks, and other imaging to make sure they're not progressing. Early on in the treatment, there are eye drops that can be used and in-office laser procedures. But when it becomes very advanced, patients frequently need to be on multiple drops and have any of a combination of surgical procedures. And with glaucoma, once you've lost vision from glaucoma, you can't get it back. So the earlier we can detect it and make sure you don't develop a problem, the better off you'll be long-term. And now just looking at macular degeneration. So this is one of the most common reasons I see patients. So this is the most common, quote, aging disease of the eye, which affects the center vision cells. So unlike glaucoma, which affected all of the peripheral vision, macular degeneration specifically affects the center vision cells. And the hallmark of macular degeneration is drusen. Drusen are tiny byproducts of the cells, and the cells collect these byproducts because they don't digest them themselves. They accumulate underneath the retina. They begin as tiny pinpoints of damage that are barely detectable on exam, and eventually they accumulate over time. It typically starts in your 50s and 60s and progresses over decades. And so as these drusen accumulate, what you can see in this bottom photo are these larger yellow circles. So these are accumulation of drusen. So this is the center of vision, and you can see these drusen in this patient all around the center of vision. And what happens is the retina that's sitting on top of these drusen can get damaged. And if those areas become large enough, they can cause large losses in the central vision. So for dry macular degeneration, the symptoms that we think of are what patients most complain about are difficulty with reading vision and difficulty with contrast sensitivity. Waviness and distortion of central vision are pretty big indicators of macular degeneration with preserved central vision. So the ability to move around your environment is totally intact, but it's the reading that is the most bothersome. In this top graphic here, what you see is early on, when you can see the whole face of the child, this is exactly what patients describe, that the face, the center of the face starts to become blurry and then darker. And then eventually, as macular degeneration can impact the dead center of vision, you can be looking at someone's face and see everything else except their face. And in this bottom graphic, what I like to point out here is the distortion that can come with macular degeneration. So distortion can be hard to tell, but in faces, it's very clear that there is a distortion of the retina. The retina's structure is uneven here, as you can see in this child's face. And this is distortion combined with blurriness in the center. Currently, the treatment for dry macular degeneration is not as good as we would like it to be, and we hope that more treatments come out very soon in the future. But we start with making sure our patients have their blood pressure under control, because that is a risk for progression. Take precautions against UV light exposure, so basically wearing sunglasses when you're outside, even in the Michigan winters. And then taking a vitamin supplement. They all say this, AREDS 2 on them. These are the vitamins that were found in a study to prevent the worst complications of macular degeneration. These are two of the most common examples of eye vitamins. You never have to get the brand name. There's tons of them and they're available everywhere. They are non-prescription vitamins. And before you start taking a vitamin, you should see an ophthalmologist or optometrist, because while vitamins aren't inherently dangerous, when you're taking a lot of other medications, you just want to make sure you're not taking too much of something or that it's not interacting with the medications that you're already on. This is a big tool that we use. It's called an Amsler Grid. And I don't know, you may have seen this, but this is the grid here on the top left. And what it is it's a grid with a dark center dot, and then all of these tiny boxes that are up and down, left and right, completely straight. And the way you use this is you cover up one eye and you stare at the center dot. When you stare at the center dot, you should be able to see that the entire grid is straight. And then you cover the other eye and look and do the same thing. We determine that there are problems or deficits in the vision when you see any of these things happening. So holes or spots in your vision, blurring of vision, or curvy or wavy lines. And this is a monitoring tool. So if I'm not seeing a patient back for 6 months, I'll ask that they look at their Amsler Grid once a week, because what I want my patients to determine is what is their baseline of vision. And once they know what their baseline is, then they can come back and say, you know what, there's a new problem here. Or they can call my office at the 3-month point and say, I just noticed something new, because that could be a sign of wet macular degeneration. And we want to see patients with wet macular degeneration right away. Wet macular degeneration occurs to 10 to 15% of patients with the dry kind. It occurs when new blood vessels, abnormal new blood vessels, grow underneath the retina through the damaged tissue and cause sudden loss of vision with bleeding and fluid in the retina. So this is the value of the Amsler Grid, is that this can be detected by a patient at home so that you're not waiting months until your next follow-up. You call the office and you get in right away so that we can evaluate this. The treatment for wet macular degenerations is injections of medicine inside the eye. We do them monthly. It's one of the things that sounds awful, but is actually incredibly effective and really not that bad. And we do this every day, all day, and it really has transformed vision loss in macular degeneration. Finally, I'd like to transition over to diabetic eye disease. Diabetes is the leading cause of blindness and vision loss in the world. This is a universal fact, and it is happening to patients younger and younger in the population. The extent of damage to the retina and diabetes, to the eye and diabetes, is closely tied to how long you've had the disease and how your blood sugar has been. So somebody who's had really good blood sugar control for 20 years may have almost no diabetic eye disease, whereas someone who gets diagnosed with terrible sugars and has a super high A1C but has only been a diabetic for a year can have tons of problems going on in their eyes. Diabetes and high blood pressure work together to cause retinal damage. So the situation is always worse when the blood pressure is not controlled. And symptoms of diabetic eye disease, besides being a diabetic, blurred vision, new onset floaters, sudden onset vision loss. But most patients really have no symptoms, again, until the very late stages because there is no pain involved. The treatment for diabetic eye disease depends on the stage of the disease. So early stages, we do a lot of blood sugar control, monitoring, counseling, and we can test patients with photos and fluorescein angiography in the office. Later on, as the disease progresses, we can inject more medication in the office and do laser treatments. And then in very advanced diseases, that requires surgical treatment. And I wanted to show this case actually because this photo shows a patient who had all of this bleeding in their eyes that could barely see out of the eye and had monthly injections and came back a few months later and looked like this. So the blood is not gone, but it's significantly better, and he's back to driving and back at work because he can see. So there is real value in making sure your diabetes is controlled and making sure that it's checked appropriately. So back again here to our chart of where to seek care. Again, I can't emphasize enough that if you're having vision difficulties or feeling like your vision is blurry, just not right, or you're having specific complaints, driving vision, reading vision, the best place to start is with a good comprehensive ophthalmologist or an optometrist who can sort of determine what are we talking about, and from there can help guide the referrals to the appropriate subspecialist to make sure that we can get you the care, the vision aids, the surgical treatment, whatever it is, to make sure you're seeing your best. These are some of my references, and I'd like to say thank you and open it up to any questions.
Thank you, Dr. Patel. Thank you so much. Folks, you can ask a question by either typing it in the chat box. On my screen, it's at the bottom. Or if you want to unmute yourself, you can go ahead and just ask a question, whatever is easiest.
Hi, Doctor. Are you able to hear me?
Yep.
Great presentation, such useful information. Thank you for that. Two quick questions. When you're treating dry eyes, is there a difference between ointment or gels? And then the second question was regarding the dry macular degeneration. You mentioned something about blood pressure control. So my question with regards to that is it worse if you have high blood pressure or low blood pressure? I guess if you could elaborate on that.
Sure. Okay, so first with dry eyes. So there are definitely a lot of products on the market. So there are regular lubricating drops, and then they market them as severe dry eye drops or gel drops. They're still drops, but they're much thicker in consistency. They still squeeze out of the bottle, but they can cause a temporary blurring of vision because they're so thick. So if your eyes are very dry, you can use those, but it is going to make it more difficult to see for a few minutes. So that's something to know. Patients with contact lenses shouldn't use those drops because that clouds the contact lens. Ointment is actually ointment. It's like a Vaseline that goes in the eye. So it's much, much thicker. I would almost never recommend that you put ointment in during the daytime. You will not be able to see. So ointment is like you are in bed, lying in bed, about to close your eyes, and then you put the ointment in. So if you need more lubrication during the day, I would definitely move to gel drops and save the ointment for bedtime, because you almost can't function with ointment during the daytime. I hope that answered your question.
It does, and actually, if somebody gets up during the night 2-3 times, is the ointment going to cause blurriness for like 8 hours or just?
No, I would say it's more like going to be an hour or so. If your eyes are actually really dry, then the ointment is still going to wear off. So no, I wouldn't imagine that it would impair the vision that much.
Okay, good.
And regarding dry macular degeneration, so all of the studies that we've ever done are on normal blood pressure versus high blood pressure. There's really not a lot of literature on anyone with low blood pressure. So it's really just about making sure you're taking the appropriate medications to make sure your blood pressure is within the normal range. There's no benefit to getting your blood pressure below 120/80. But the studies had looked at pressures, greater than 150. So it's not a low blood pressure issue. It's definitely a high blood pressure issue, and making sure we're controlling high blood pressure to bring it into the normal range.
Thank you so much.
Dr. Patel, we have a question in the chat. Do certain Parkinson medications affect your vision or precipitate vision problems?
So this is a very common question, and I'm going to defer this a little bit, because if you've ever read the packaging or the package insert on pretty much any medication, one of the side effects is always blurred vision. Hands down, blurred vision is on a list of things that every single medication can cause. But very few medications truly in the world of medicine cause real eye side effects. So no, there's typically not something that a specific Parkinson's medication is going to do to cause more vision problems. But if you have a concern about your specific medication, I would talk to your neurologist about it. An ophthalmologist can look into that. But I have not, on my end, ever seen a patient where we've stopped any neurologic, not neurologic, any Parkinson's medication. There are specific medications that have been known to cause eye problems, and we are required as ophthalmologists, or the neurologists are required to send them to us to do vision screens, but none of the Parkinson's medications are on that list.
Okay. We've got a lot of questions in the chat. Here's another one. Do you perform a treatment for dry eye with a patient's own blood serum?
So there are they're called serum tears, and there are only a couple pharmacies that do them. There is one up here on Telegraph in like North Bloomfield Hills. And what they do is they draw your blood, they spin it down, and then they make artificial tears. They give you a bunch of vials that you use, 1 vial a day. So those are wonderful treatments for patients that it will work for. It's not the standard of care, I would say. It's not as easy to access because there aren't as many pharmacies that will do that. They're all out-of-pocket expenses. So those are definitely options in the dry eye algorithm. It's just not not what we go to first.
Okay.
We have a question.
Yeah, can dry eyes affect your vision if untreated?
Yeah, so I guess the question would be, could there be permanent damage if left untreated? So dry eyes would have to be very, very severe for a very long time to cause a permanent vision loss. But the problem with dry eyes is that unless we address the underlying problem, it keeps coming back. So just because I lubricate the eyes today, if there is still a problem tomorrow and we don't take care of it tomorrow, the dry eyes are just coming back. There are a few complications of dry eyes that can lead to, you can get decreased sensation of the front surface of the eye, which can lead to scratches that you don't know about. Scratches then can become infected or scarred. So there are some long-term complications. Most patients don't get to that point. For most of our patients, the issue is that we are trying so hard to keep the eye lubricated, to get it lubricated and keep it lubricated over time. And that's the source of the vision problems, not the chronic complications of it.
I have a question.
Go ahead.
Hi, I'm going to have a bona fide barium swallowing test shortly, and I was intrigued by the fact that swallowing is a symptom of some eye issues with Parkinson's. Do you know how that gets connected? Why they have tremors, rigidity, anxiety, and balance, which I recognize as Parkinson's symptoms. They also have swallowing, and I'm going for a swallowing test, and I don't know how they're connected.
So to be honest, I'm not sure I know that Parkinson's patients can have difficulties with swallowing as part of the nervous system dysfunction. And
Right.
the eye issues also as part of everything we've discussed, but I don't know, and in all of the stuff that I researched and I've learned, I don't know the connection between the eye difficulties and the swallowing difficulties. And I apologize for that.
So you don't know enough to know if they're correlated or not.
Yes, if the eye is correlated to the swallowing. Now,
Gotcha.
the eyes are so the one thing with dry eyes and tearing is that the tears drain down through the tear ducts, which go into the back of the nose. And so that's why sometimes when you have, I don't know if you've ever used eye drops, you can almost taste them because they drain through your nose into the back of your throat. But beyond that, I'm not aware of the connection of the eyes to swallowing itself and the need for the barium swallow.
Do you have any other questions?
No, thank you.
Thank you.
Mhm.
Dr. Patel,
Yeah.
I went to optometrist
Mhm.
about 3 or 4 years ago in Traverse City, and for a regular check. And she told me to use fish oil, a specific brand for the dry eyes. So I did. This was 3 or 4 years ago, and it seems to have cleared it up. Is that something that I'm just imagining that's getting better, or is this something that is of widespread use?
Fish oil can play a very important role in dry eye management. So there are some fish oils that have a greater benefit for dryness. And it really depends on why you have the dryness, but it can help with the glands to produce the more lubricated parts of the tear film, or a certain part of the oily part of the tear film. So fish oil can definitely play a very important role. And there are some fish oils that are better, some krill oils that certain people recommend that can improve tear function. Yes, you're not imagining it.
Thank you.
Mhm.
Okay, I have a question in the chat.
Sure.
I have double vision. I can't read. My ophthalmologist has prescribed glasses where one lens is covered so that my left eye will focus. It's not working because my right eye wanders around. What can I do so that I can read? Is there anything that can be done?
So this is probably when I would refer my patient to so this I imagine was a comprehensive ophthalmologist. So there's 2 avenues that I would go down. So this is when I would refer someone to an adult strabismus doctor. So the field is pediatrics and strabismus. So they're children's and adult strabismus doctors. In their office, they work with orthoptists who are special technicians of eye muscles. So those are really the experts of prescribing prisms, and making sure they're in the correct place. But if that's not working, that's when I would refer my patients to a low vision specialist. In the Metro Detroit area, probably the most prominent group is out of Henry Ford Hospital and a few satellite locations. They spend a lot of time with their patients to fully understand what can be done. And they frequently have more aids than what you can find in a regular optometrist or ophthalmologist office.
Okay, thank you. For those of you, this is a statewide presentation, so I would recommend that you look at your local healthcare system's website and look for a low vision specialist if you're not living in the Metro Detroit area, which I know a lot of you are not. We have another question in the chat box. I have Parkinson's and have been diagnosed with macular degeneration, glaucoma, and low eye pressure, detached retina. Is that typical? I'm also colorblind.
It's not typical, but it's not uncommon. So if you took the Parkinson's away from it and somebody told me they were diagnosed with glaucoma, macular degeneration, or low tension glaucoma, macular degeneration, and had complications of that, I would say that's kind of standard. I mean, that's not uncommon that we see patients with complex eye conditions. The Parkinson's adds a whole different level to that and a whole different need and reliance on your vision, but it's not uncommon because the macular degeneration and glaucoma, again, are aging diseases. So they happen to our patients as they age and are totally independent of the Parkinson's.
Okay. All right, thank you. Doctor, there's been many questions asking if you are taking on new patients and patients specifically with Parkinson's.
I am taking new patients. I will be perfectly honest, I am a retina specialist. So I am happy to see any patients. And one thing I do, and I like to be able to do in my office, is to see patients and direct their care, because I understand that with the eye itself, it can be very hard to understand what the problem is and where to go from here. And so I am more than happy to see patients and help coordinate. If I think you have a glaucoma issue and it's not a retina problem, then I will help you connect you to the best glaucoma specialist in the area. If we need a strabismus doctor, a low vision doctor, I can help make all of those connections and referrals as necessary. So yes, I'm happy. And if you need to, Mary Sue can send out my office phone number, and I'm happy to see if this would be the right fit for you.
Okay, thank you.
We have another question.
Sure.
Hi. I have been taking a lot of Cinemet and other related drugs for about 10 years. And I'm recently getting a phenomenon where I have like millions of little black dots that are in my white sink. And sometimes I see like black I don't know how to describe them. They're like, if I'm watching television and there's a man with a white shirt on, he'll have black stripes on his shirt.
The white background on it.
On the white background of the shirt. And I don't know what the heck that is. Is that anything you recognize?
So the black dots are very common. The black dots are floaters typically in the eyes. So, and you see them more commonly on a light background on a sunny day. And so those are the vitreous gel. We have a gel inside our eyes, and with age, the gel degenerates. And many patients can see those little areas of degeneration as little black spots, little black dots and floaters. So those symptoms can range, and typically they fluctuate a little bit. Like some days they feel more than others, some months and years they feel like there are more than others. And in certain lighting conditions, they feel more significant than in other times. The black stripes, I'd have to get more information, but those could be two things. First, it could be more floaters, just seeing them differently. But sometimes that's actually our brain's processing of the visual information. So our retina captures the light, but it doesn't capture the light as a, as a person's face or as, wallpaper on the wall. It captures the signals as red, blue, green, and as certain very concrete signals. All of that information goes to the brain, to the back of the brain, to the visual cortex, to be separated and then travels to other areas of the brain to be processed. So sometimes if there is a disturbance in those connections and those systems, we can start to see things that are not there truly. And it's our brain that's misinterpreting the signals that's coming into the eyes.
So is there any treatment for it?
For the floaters, no, we just watch them. Once we know that they're just floaters and there's nothing more that needs to be treated, then usually patients get used to them. And in terms of the visual input, again, we like to make sure there's nothing there physically that we need to deal with in the eyes, and work with the neurologist to make sure there's nothing that needs to be treated on the brain end or nothing has changed. And at that point, it's just a matter of knowing that this is what it is.
Okay, thank you.
Okay, folks, we've got time for one more question. Anybody want to ask? Unmute yourself if you've got a question. We can take one more.
I have a question.
Okay, go ahead.
Does glaucoma and dry eye cause any pain or soreness of the eye?
Glaucoma does not. Glaucoma is completely painless. Most cases of glaucoma. Dry eyes have tons of symptoms. So pain, soreness, sometimes achiness, irritation. Sometimes when our eyes are dry and irritated, we rub them a lot, which causes more soreness and irritation. So if you're having pain symptoms, that's definitely a reason to come in. But more commonly, pain is associated with problems on the front surface of the eye as opposed to inside the eye.
Thank you.
Okay, Dr. Patel, this was a wealth of information. Thank you so much. I'm getting lots of requests for your slides. Are you willing to send them to me so I can send them out to the rest of the crowd?
Yes, I will.
Thank you.
Of course.
The other thing is, folks, we recorded this evening's program. So in a couple of days, I will have it posted to our YouTube channel if you need to review any of the information. But again, Dr. Patel, thank you so much. This is one of the best presentations.
Thank you.
It was really great. Thank you all.
Of course.
All
Thank you. Have a
right.
nice night.
Good night.
Hello,
all.
Dr. Patel.
Bye-bye.
Bye. Thank you.
All right.
Thank you.